Of you guys here already know Mike, so for those of you that don't know him, Mike, he's with Boston Scientific, and I'm not going to go too far out, Boston Scientific and Advanced Bionics. His educational background has been chemistry at Cal State, at CSUN, electrochemistry at UCLA, and PhD at Caltech and USC combined. So today, we're really honored to have him here today with us. We see him every day, but we were hoping that we'd get a bigger crowd today to talk about these spinal cord devices that we have, that we develop in our company and we sell. So hope that you will enjoy tonight's lecture. Thank you.
Thank you. Good evening, everybody. So what I wanted to do first was kind of give you an overview of what our Boston Scientific is all about and our products and kind of how they work. And then I also have a presentation on healing and the foreign body reaction if you guys are interested. So I guess we'll play it by ear. So typically what a patient does when a patient that has chronic pain is basically they get a referral. This is basically an SCS clinical pathway, how they actually end up getting a device. They have chronic pain, obviously. They might choose some of the therapies such as low back surgery or heavy duty medications. If they do choose SCS, they end up going to a doctor basically. At that point in time, they might think that it's too invasive and they might not get a trial, revert back to maybe surgery or medications. If they do decide to go forward, they basically go in and do it. We basically implant a trial device. They basically take it home and use it for about 3 days to 7 days, about a week, and they evaluate it, see if they get a 50% reduction in pain. If they don't get a 50% reduction in pain, which is about 35% of the patients, basically they pull out the trial device and they no longer get a device. The remaining 65% of the people who do get a 50% reduction in pain, they go into the OR, they have the procedure done, which takes about 3 hours. There's a post-OR programming that we help them with, which takes anywhere between 15 to 60 minutes, 15 to 60 minutes. And then they go, they get follow-up 3 days, 1 month, 3 months, 6 months, those kind of things. And then basically they use it at home and they come back and visit their physician. So I'm going to talk about the SCS components first. We have the brain of the device, which we call an IPG, which basically is an acronym for implant pulse generator. It's basically got a rechargeable battery inside and all the electronics to deliver the stimulation. And we'll go through each of these components individually. We have a trial stimulator. We have an IPG charger to charge this device. It's a rechargeable device. We have a patient remote and then a navigator program. If you have any questions, please.
What is SCS?
Oh, I'm sorry, spinal cord stimulation. Spinal cord stimulator. So it's, I'm going to describe the surgery in a little bit. So just to recap on the rechargeable, basically IPG, it has 16 independent contacts. They're independently current regulated outputs. And that's going to be a little important because one of the things that happens when you implant anything into the body, it tends to form a fibrous capsule. So therefore, the amount of current needed to retain the therapy might have to be increased, and you can do this at 16 independent outputs. It was the first rechargeable neurostimulator. We introduced it basically back in Q4. We've implanted 65,000 units so far. And so far, Medtronic and ANS, they followed suit and also came onto the market with a rechargeable device. So we're going to talk about leads, and we're going to talk about percutaneous leads and paddle leads. These are the device that gets implanted in the epidural space, and I'll come back to that. The Bionic Navigator basically allows the patient to play around with a joystick kind of control to adjust currents in like 1% increments, and it basically aids to program the patient so they get better therapy. We did say that our IPG, or our device, was a rechargeable device. basically there's a wall charging unit that basically charges this charger. And this charger is in the device that basically transcutaneously charges the battery inside the device. So it's a cordless charger, and it allows the patient to charge, to be ambulatory while charging. Okay, so here's our device. This is our trial stimulator. This is the device that's basically connected, basically we use to do the trial test. And then this is basically our remote control that communicates with our IPG. And we're looking for, again, 50% reduction or better in pain. There's basically a cartoon showing you how they charge it. Here's your charger unit. You either wear a belt around the abdomen or you use a double-sided sticky tape. Basically, you put this charger on the outside where your IPG resides, and you basically charge it. It charges and basically will beep you to tell you when the battery inside the device is fully charged. And people usually will charge for, say, 1.5 hours per week or somewhere around 15 minutes per day. So it's up to the patient. Any question?
So the charging is through electromagnetic?
It's transcutaneous through the RF coupling. Okay, now I'll tell you a little bit about the procedure. So the patient's prepared aseptically, basically is cleaned up so that it's aseptic. The physician basically determines where they want to put the leads. So for example, if you had shoulder pain, you're going to put the leads up here in the cervical region. If you had lower back pain, you're going to put it back here and basically around thoracic and like the T8. But if you had lower, extremity pain, you're going to put it down here at probably L1, T12. So the physician determines where he wants to put the lead tip based on where you have the pain. He uses fluoroscopy to identify where the vertebrae are, and then basically marks the desired level where he wants the leads to land.
Mike, is that the nomenclature for the basically that you're talking about the spinal cord? Is that you mentioned L1s and?
Well, you got C1 through 7 up here, then you have T1 through 12 here, and then L1 through L5. And it's numbered from the head towards the feet. Okay, so if you're going to put in a percutaneous lead, that was the lead that let's see how do I go back. The percutaneous lead is basically this one. That one you can put through a simple needle. This is called our paddle lead. That basically has to be surgically implanted by a neurosurgeon. This can be put in by an anesthesiologist. So now we're talking about a perc lead.
What's the diameter of that percutaneous?
It's about 50 thousandths. So pretty small. Okay, so if you're going to put in a perc lead, basically they palpate and use fluoroscopy to determine the intervertebral space. They basically insert the needle. They confirm that they're in the right location with fluoroscopy and loss of resistance. And then they basically insert a lead containing a guide wire. And then they confirm the location based on landmarks to verify that the very tip of the lead is basically where they want to locate the lead. And then typically, physicians will put in bilateral implants. They'll put one basically a little bit to the midline on the left side and one a little, paramedial on the other side. And they'll either put the two lead tips where basically they're aligned or they'll be offset, depending on what kind of therapy. And then they undergo intraoperative screening. Here's the trial device that's connected to the lead that goes in the body. So for the trial procedure, the lead is percutaneous, is coming out of the back. And they try different electrode combination polarities using that bionic navigator that we saw before. So here's kind of giving you a cartoon. Here the lead has been placed in the epidural space. It's taped off, and then it's connected to an OR cable to our trial stimulator. And that's basically fixed to the skin, and that's where we send the patient home for approximately a week, hoping that they'll get 50% reduction in pain or better.
Question.
Is this in essence doing the same thing as an acupuncturist would do with the needle? Similar, would you say?
This is quite different.
Quite different.
Yeah. In acupuncture, usually you're actually directly stimulating the nerve, but it's a peripheral nerve, where this is actually stimulating the actual dura on the spinal column. Well, and then when you're ready to do basically you're done with a trial and you're ready to go to the real McCoy, basically you make a pocket on the buttocks, and basically you have the lead coming out of the epidural space. You tunnel the lead from the epidural space, make a tunnel down to the IPG. You place the lead into the IPG, and basically that's placed into the pocket. These both are sewed up, and you're ready to go. Okay, the paddle lead we looked at was a wider lead, and that's typically put in by neurosurgeons where they perform a laminotomy. Laminotomy is basically you remove some of the bone of the vertebral process so you can access basically the epidural space. One of the advantages of putting a paddle is since it's wider and bigger, it doesn't tend to migrate. Because one of our major problems with spinal cord stimulators with the Percleys is they tend to migrate up and down. That can be an issue. You basically have to go back to the physician and reprogram it or readjust the lead. With the paddle lead, we don't have that, not much of that kind of problem because it's much bulkier and gets fibrosed down. And this is basically showing how you anchor the lead so that you don't get migration. You basically suture down to a ligament. And then basically this is showing you how you place the lead into the IPG. The proximal limb gets placed in here, and this is where you make electrical connection from the inside world to the outside world of the electronics. You x-ray the whole system, make sure everything is where you want it. You close the incisions, and then you optimize the parameters with the program stimulation. And that's basically now where you program it so that you get optimal efficacy in pain reduction.
You control when your pain by that?
Yes, correct.
Who does the programming?
Usually we have a sales rep that basically assists the patient at that point. And there's an algorithm we have that basically greatly speeds this up so that you don't spend a lot of time.
Is it current pulses, the
Yes.
amplitude, or is it the frequency, or is it a combination?
All of the above.
All of the above.
Yeah. We typically stimulate our patients at say like 100 hertz, something like that. to give
Is
you
it a
an-
square wave, or is it sinusoidal? Or
It
does matter, or
looks
bend?
pretty much like a square wave.
Mhm.
So you can vary the pulse width, you can vary the frequency, you can vary all of those things. Any other questions?
Any kind of side effects? I mean, can the patient kind of like overdose? You know,
If you stimulate too high, you can get pain. You can innervate pain fibers, and it can be painful. The other side effect is when you block the pain, the patient has a sensation what they call paresthesia. It's kind of a tingling sensation. So in lieu of the pain, you kind of feel a tingling in your back. About 75% of the patients comment that they don't really like that tingling sensation, but if you compare that to the pain, they will take the tingling, paresthesia.
So it's the stimulation of the nerves that are damaged that actually cause the pain, or?
Correct. Well, you're actually stimulating above, and basically you're blocking the pain transaction up to the brain.
And what's the prerequisite for the patient? Is it any kind of pain, or from the
You know, there's a pain scale that they go to when they go to a pain management specialist, and basically there's a series of questions they ask them. And usually most of these patients, as you can imagine, are in pretty severe pain. So it's
regardless of the reason for the pain, it doesn't matter.
well, yeah, there's a lot of factors, but most of these patients, I say, that are in quite a lot of pain now. It varies from limb pain to lower back pain to shoulder pain. I mean, there's a lot of parameters you got to put into the equation, whether they get an implant or not.
cancer, for example, cancer usually at certain stages will cause a lot of pain. Is this a device that could be applicable to?
I don't think most of our patients, very few of our patients are cancer patients, actually.
Are they accident patients who have brain accidents, or is it just naturally developed pain?
All of the above.
And, go ahead.
Your doctor recommend to get this done, or the patient needs to have the knowledge of this device being out there? And that's
Unfortunately, I think there's a lot of pain doctors out there that are not even aware of spinal cord stimulators. So I think it's really important for the patient to get educated and know all the options. Because I think many physicians will tend to put you on painkillers before they will consider doing them. And this is somewhat invasive if you don't need it.
And you have your own neurosurgeons that your company recommends, or you go to anyone?
You'd probably go to your own personal physician. But I mean, each doctor, I think, has their preference in which device they want to use. So you might not end up getting ours.
What's the maturity level? Is this like a mature product in your?
SCS treatment has been around for about 30 years, so it's pretty mature.
Is this applicable to migraine headache?
Migraine headaches is going to be another application we're going to be looking at, but you stimulate different nerves. So I think you'll see in the next 3 or 4 years, SCS you'll have SCS being used for migraines.
Mike, how about insurance coverages? Does insurance actually pay patients?
Yes, you have to meet certain criteria, but yeah, there's insurance usually picks up SCS.
And would that be that this will help for a while and then would stop? Has that happened at all?
Yeah, if the lead migrates significantly, then you only have 2 choices. You can pull the device out, or you basically have to refit the patient. But the good thing is, usually after about 2 weeks, if the lead doesn't migrate, you get fibrosis of the lead in the epidural space, so it doesn't move any longer.
You said tingling is one of the side effects. What other side effects?
I think that's the major one that I can think of. I can think of any one. And the fact that you have to remember to charge it, which for some patients is inconvenient. I mean, you could be in the middle of a vacation and not charge it, and then all of a sudden you're in pain. But yeah, I think that's fine. And
can somebody wear this for decades?
Yes. Yeah, it's completely implanted.
It's we say what 10 years.
10 years is I think the warranty. I think they'll probably last a lot more than 10 years, but that's what we warranty them for.
The difference between the paddle and the lead as far as functionality, is there a difference?
Well, the advantage with the paddle, as we said before, it tends to keep it from moving.
Is that
the other thing is it tends to be bulkier, and you tend to get, I think, more pressure of the actual electrodes on the dura of the spinal column. So I think you actually get better results with the paddle.
The coverage of simulation is also
simulation coverage is better.
Could you give us a ballpark how much this procedure would cost the patient?
The whole system would be around $25K, and I think the procedure probably is about somewhere in the same ballpark. So you're looking at about $50,000.
No wonder doctors are prescribing pain medication first.
But if you do the numbers over the lifetime of a patient, this actually will save you a lot of money down the road.
No question about it.
Yeah.
Has there been a case that the body rejects this device?
That's very rare, because all of the metals and plastics and ceramics and everything we put in here are highly biocompatible. But you will find a very small percentage of people that will be allergic to some of the plastic or the metal, but it's very rare.
What kind of a coating do you use on the percutaneous catheter that goes inside the body?
What kind of coating?
Yeah, those are not exposed. polymers or metals?
Yeah.
Is there any kind
These are basically electrical contacts that actually do the stimulation itself. The lead body is made out of polyurethane.
No additional coating on it?
No, there's no additional
Like
coating.
Paralin?
No,
Nothing?
no. Actually, we don't want coating on the actual contacts. So that's
That's
what,
true, I understand that.
Yeah. I mean, there's been studies where they put heparin, for example, or they put anti-chemicals that basically are trying to block.
The salinity is the most.
Yeah,
is
yeah.
the most
But
dangerous.
no. And this basically is also electrical contacts with, actually it's silicone, and then it has polyurethane lead bodies.
Ross, the person that designed what does the reflow and does the lead panel is sitting right here. He's taking pictures today, so.
Oh.
If you have any other questions for you, you can go.
So Sassoon, did we want to go to the next topic, or?
So I think the next topic is actually a continuation of your question about the foreign body material.
Do we want to go on and do
that's
that?
something that
You guys
we're
want to do that?
interested, we can move to that and then come back.
The next topic is something near and dear to me. I've been working on it for about 30 years. It's maybe my hobby, but it has to do with heating and the foreign body reaction. And just real quickly, I'll go through these kind of fast. I won't go into any gory detail. But obviously, when you basically have a wound, the whole purpose is you want to restore tissue organ function, you want to prevent infection, prevent blood loss. And here are the 3 types of implants that we have here in the United States and Europe. Class 1, 24 hours or less. Class 2, 1 day to 30 days. And where we fall is class 3, where we have the implant 30 days or longer. It's considered basically long-term. And these do require animal studies in both the U.S. and Europe. In terms of the different medical implants, we have the different types. Allografts, for example, when you transplant beta cells from one patient to another. Ophthalmic implants in the eyes, orthopedics in the hip and knees, peritoneum drug pumps, blood. We have long-term glucose sensors, for example, cardiac pacemakers, heart valves, defibs, soft tissue pacemakers, and then the brain neurostim electrodes. So we have implants all over the body in every possible tissue type. Soft tissue, bone, blood-brain barrier. And I guess the million-dollar question is it one of the things I've been focusing on for a long time is it possible to develop stealth medical implants? In other words, that the biology of the person doesn't impede the function of the device. And I'll show you a couple of examples where we can. So what I want to briefly talk about is after you do an implant in a patient, you basically have an injury, obviously, and we'll go through each of these. Protein fibrin adhesion, you'll have acute inflammation, you'll then form a provisional matrix formation, you'll have a proliferative phase, granulation tissue, a remodeling phase, for foreign body reaction, and then fibrous capsule. And that is all tied together. So whenever you damage a cell, the first thing you do is you break the cell membrane. That releases a nasty phospholipid called arachidonic acid, and that's broke down by certain enzymes in the body that forms molecules that are immune moderators, leukotrienes, LC4, D4E4, prostaglandins, and prostacyclins. Those are all things that cause issues in the body. So here's kind of a timeline. So when you break a blood vessel, you basically get mast cell degranulation, which goes and causes vasodilation, causes endothelial cell contraction, increased vascular permeability. This produces chemicals that recruit neutrophils. You get neutrophils immigration. You get diapedesis of red blood cells into the body, and then you get lymphocyte immigration. And then finally, you get formation of macrophages, fibrin deposition, and fibrosis. So that's kind of the timeline along the top. So you have edema, pus, and basically resolution. We're going to go through these in a little more detail. That's kind of a cartoon what's going on. One of the first things that happens when you implant in the body is when in seconds or minutes you form reversible and irreversible protein adhesion to the implant. You can't get away from that. No matter, all implants will get protein bound to it within seconds. Some of it binds permanently, some of it is reversible, but eventually you get irreversibly bound protein. Here's just an example of a red blood cell and fibrin. So you include fibrin and platelet deposition that kind of get caught in the thrombus formation. And then you activate both the extrinsic and intrinsic coagulation systems, which is basically complement activation. So after you do the injury phase, you enter into the inflammatory phase. This typically occurs within the first 1 to 6 days. The response is to limit and prevent further injury, to limit inflammation. You want to develop hemostasis. You want to seal the surface. You want to remove necrotic matter, tissue and debris. And you want to basically bring in cells by chemotaxis, cytokines, and growth factors. So initially, you have local vasoconstriction, and then that's basically followed by vasodilation. So there's a lot of different chemicals competing with each other. So when you injure a vessel, basically you expose collagen that's underneath the endothelium, and that activates platelets and Wilbrandt factor, and that basically activates the whole coagulation cascade. You plug the hole, or try to plug the hole, with platelets and fibrin, and you start to form what we call a provisional matrix, which is platelets, fibrin, and fibronectin. The fibronectin is kind of the glue between the platelets and the fibrin, and then you get platelet aggregation, which is mediated by thromboxane and platelet factor 4. So we're starting to get coagulation already. There's an example of a red blood cell and platelets, and then the little lines between are fibrin. Here, I know you can't see it, but this is basically the coagulation waterfall, where you have the extrinsic pathway where we deal with when you're implanting medical devices, and then you have basically the more natural intrinsic pathway. So we go along this pathway. Bottom line is we end up taking fibrinogen and fibrin and forming a cross-linked clot. Okay, one of the first cells, white blood cells, that is recruited when you implant a device, and this here is a neutrophil that's eating an anthrax bacteria. So it basically phagocytizes the anthrax, but it's the most abundant white blood cell in the bloodstream. It's about 60% of all white blood cells. They're recruited to the site of injury within minutes. It's the hallmark of acute inflammation. So if you go get a blood test and you have neutrophils, you know that you're in the acute phase and not further along. And then basically there's all these chemical moderators, such as interleukin, IFN, C5a. They also are the predominant cells that occurs when you get pus in the wound due to its whitish yellow content of the neutrophils. The second cell that gets recruited are called monocytes. These are these kind of H&E stained things that are multi-lobal nuclei. And they have basically two functions in the body. One is they replenish the macrophages that get eaten up. And the second is they serve to develop more dendritic cells. They're also phagocytes. They eat foreign material. And yeah, we talked about the staining. So they're white blood cells produced by the division of monocytes. So monocytes basically divide and form macrophages. Again, we said the role is phagocytosis. They engulf and digest cellular debris, pathogens, either as stationary as mobile cells. They move by action of amoeboid movement. You can see them sending out their pseudopods, so they actually move around from the pseudopodia. And they release proteases, chemotactic factors, again, arachidonic acid metabolites, very reactive oxygen species, and growth factor cytokines. So they basically go and eat foreign materials and then dissolve it. That's their function. So when the macrophages come into play, they appear at about 24 to 48 hours after the neutrophils are done. So we said neutrophils come in first. They're like the first 24 hours, and then they kind of die off because they have no way to replenish their nodules. Then the macrophages come in. Here's some other pictures of macrophages. Here, you got a macrophage that's going after some bacteria by sending out a pseudopod to kind of pull it in. Kind of interesting. They kind of do the same activities as neutrophils. Again, they release a whole kitchen sink of growth factors, fibronectin to cause clotting, collagenase and elastase to basically fill in the gap in the wound. And they activate fibroblasts, endothelial, epithelial cells to form granulation tissue, which is going to be on the next slide. Any questions? I hope I'm not going to bring into too much detail, so I'm just kind of trying to skim over the top. The reason why I included this slide is here's a macrophage, and all these arrows are connections between all these cells, how they communicate with each other. I mean, neutrophils communicate with macrophages, they communicate with platelets, they communicate with epithelial cells forming growth factors. T cells and B cells, which we're not going to talk about, also communicate with macrophages. Fibroblasts, the one that forms the fibrous capsule also. So just to kind of recap, first we get platelets when we have cell damage, followed by neutrophils, and this is a time scale, followed by macrophages, then lymphocytes, fibroblasts, and capillaries. So now we're trying to fix the wound. We're now in wound healing. So before we can completely fill in the wound, we have what we call a provisional matrix, and it's basically a 3D structure of fibrin deposition. Again, we have all these chemicals, chemoattractant, cytokine, growth factors. That's actually pretty important. The matrix that happens during the provisional matrix, basically the types, concentration, and conformations of those first proteins that bound to the surface ultimately are going to determine the body response to the implant. So when you take an implant and put it in the body, those proteins that bind to the surface of the implant within the first minute are going to determine the outcome of that device. That's pretty interesting. Again, neutrophils, macrophages, fibroblasts. So this basically kind of giving you what's happening in inflammation, proliferation, and then maturation. Basically, you're filling in. Your lymphocytes are starting to drop off, and so your fibroblasts are starting to drop off. So now you're forming fibrin. So proliferative phase, now you're trying to fill in the wound area. It occurs a few days to a few weeks after the injury. And everybody's familiar with granulation tissue. It's very red, very vascular, bleeds very easily. It contains macrophages, fibrous connective tissue, newly formed blood vessels, so that's why it's very red. You have a lot of blood. And you have fibroblasts, which are actually microfibroblasts, which are these guys down here. They actually try to pull the matrix, and actually from a molecular standpoint are closing the wound. They're actually pulling the wound closed. And that's just a picture of collagen. Collagen is very tough. It's a triple helix. I'm going to skip this one. Well, first, the body deposits a very random, disorganized collagen, which was what we call type 3. It's basically fill the gap as fast as you can. But then, after about several days, up to several weeks, the body replaces this type 3 with basically a type 1. And why is it type 1 better? Because it's more organized, more cross-linked, and it's basically now repairing the damage. Wound strength. At 6 weeks, it's 60% of the original strength. So if you cut yourself, and at 6 weeks, that wound is 60% of the original strength it was. You'll never recover full strength in a wound. You will only get 80% maximum. So where you cut yourself and you have a wound, it will never be the same strength as it originally was. So at 6 weeks going forward, the amount of collagen stays the same, but all you're doing is increasing the density and cross-linking and how well it's organized.
When you see scarring, what are you seeing really? Can you explain scarring in any of these?
Oh, we're going to come back to that. I'll talk about scarring. And this is epithelialization. That's basically the skin that forms on the outside of a wound. Basically these grow and they leapfrog each other until they have contact inhibition, until they touch each other again. When they touch each other, there's contact inhibition, they quit growing. That's when they know that the wound is closed. Real quickly, this is a cartoon. This is a bacterial infection. It gets into the body. It gets opsonized, basically. It gets antibodies put on it. That's how the body recognizes it as being foreign antibodies on the outside of the cell. It then gets recognized by white blood cells. It gets engulfed. The white blood cells secrete a bunch of superoxide and acids and so forth, and basically it basically kills the cell. So that's the bottom line for how the white blood cells work. Remodeling phase. Now the incident is over. Now the body's trying to basically get back to status quo. So again, we talked about type 1 replaces type 3 collagen. You have decreased vascularity. You don't bleed as much if you poke yourself in the wound. You have less fibroblasts and hyaluronic acid. Your nerves regenerate at about 1 millimeter per day. Accelerated wound healing. If you happen to cut yourself in the same spot, it will heal a lot faster the second time around than it did the first.
Mike, how about the age factor?
Age factor comes into play. You'll heal a lot slower as you get older. And also pre-existing conditions like diabetes, those kind of things. You won't heal as well either. So here we're just again looking at a time frame. As time goes on, your bone breaking streak basically goes and kind of levels off. And you start converting collagen, that should be collagen 3 to collagen 1. Okay, foreign body reaction. So we basically know we have macrophages coming in, trying to basically debride the area and form granulation tissue. But when you put a foreign body, an implant in the body, the white blood cells cannot basically digest the implant. So now you're stuck. You have a chronic inflammation going on, and this is characteristic of where you're basically generating what we call foreign body giant cells. It's basically the hallmark of chronic inflammation. And what you're going to end up doing is encapsulating the device due to the chronic inflammation. And what happens is those macrophages we talked about before that were trying to dissolve the device, they basically they become frustrated and they basically give up. Because what does the body try to do? First, it tries to dissolve the implant and get rid of it. And if it can't, what does it do? It basically tries to sequester it and wall it off as though it doesn't exist. So the foreign body giant cells are formed by the fusion of frustrated macrophages. Basically, it's one soldier. All the soldiers get together. Now you have an army. That's the whole point. And they basically, such as implants that are too large to be phagocytized, but for example, talc, silica, or asbestos fibers. So in a foreign body giant cell, you can have as many as 100 macrophages that fuse together, and you'll have 100 nuclei. The giant cells secrete degradative agents such as superoxides, free radicals, causing local damage to implant and other foreign bodies. Let's look at a picture of a foreign body giant cell. These right here are foreign body giant cells. The white part in the middle is a multifilament suture. So the body does not like that suture. So it's sent in neutrophils, it's sent in monocytes, it's sent in macrophages, and now the macrophages are completely frustrated and they fuse together and they form what they call foreign body giant cells. And these will completely encapsulate around this device and they will live there for the duration of the device. Here are some more foreign body giant cells. You can see them up here and very clearly here. This is a some vegetative matter that was inhaled into a lung of a patient, and you can see the foreign body cells also trying to degrade the trying to dissolve the implant. So in my opinion, you know, I guess the question is, are foreign body giant cells more or less inflammatory than macrophages? In my opinion, they are. I don't think there's got to be a reason biologically why they fuse and they group together. It's not known whether they remain activated, releasing their lysosomal contents, or become quiescent. So now you have a foreign body medical implant in the body. Those foreign body giant cells and macrophages will reside on that surface of that implant for however long you're alive. And they tend to be quiescent. Finally, they give up, but they kind of rest and go to sleep, and they're waiting for something else to induce that chronic foreign body reaction again. So they'll stay there and live on that device. So what happens next, if the foreign body cells give up, they recruit fibroblasts. Now the time is, you know what, they want to recruit the fibroblasts to come in and basically completely sequester the implant with a fibrous capsule. So your question, Daniel, was, what is a scar? It's usually collagen. Basically collagen that's filled in. When you have a discolored tissue growth in a scar, it's collagen and fibrous capsule. So encapsulation or fibrous capsule is an avascular collagen shield formed around the body. It's developed as a protective measure. It causes problem with devices. If you're, for example, in our spinal cord stimulator, if we get fibrosis around the lead tip, what do you think happens to the current going to the spinal column? It drops. So that's something that doesn't work in our favor. So what if you have a glucose sensor underneath the subdermal glucose sensor? And you start to get a fibrous capsule, what happens to the glucose sensor? It quits working. Also, foreign body reaction can lead to chronic pain and device rejection and failure. It's pretty common in breast implants, for example. To get a breast implant and basically be in total pain that you have to go in and basically remove it. The amounts of the foreign body giant cells and the capsule thickness you get depends on the surface roughness. The more rough the surface, the more fibrous capsule you get. It also depends on the chemistry and the weight. The heavier the implant, the thicker the fibrous capsule. We actually went, like a pathologist in IT UCLA, and interoperatively we measured the fibrous capsule of this lady that was going from a 4-pound breast implant to a 5-pound breast implant. And we measured the fibrous capsule around the breast implant was 1 centimeter thick. That is amazing. That's 1 centimeter of a fibrous capsule. So usually you get a layer or two of macrophages and foreign body giant cells, 1 to 2 layers thick. And you usually have a fibrous capsule 200 to 400 microns thick, but it can be up to 1 centimeter.
And that 1 centimeter was for like, it accumulated in how long time? For like years? Several years?
This patient had the breast implant for about 6 or 7 years. But it was a 4-pound implant. So the heavier the only way the body can basically maintain that is just build more.
1 centimeter is probably not all around, is it? Is it all around?
It was more on the bottom, where the weight.
Right, yeah.
It was about, I'd say 600 centimeter on the top.
Millimeters.
I'm sorry, 600 millimeter. Okay, what else? I just have, real quick, these are some fibrous capsule around the pulse generator. There's 100 micron, so that's about 150 micron. Here's a fibrous capsule around the lead. And that's just looking at microscopic slides of what fibrous capsules look like. But they can have a lot of white blood cells combined in them, but they're just basically collagen. And they can be somewhat porous with blood vessels, for example. So if you have light and small implants, you tend to have much thinner fibrous capsules. If you're very small, you're underneath the critical surface area per unit volume, you don't get any fibrous capsule at all. So the moral of the story is if you want to make a glucose sensor or a lead that doesn't get a fibrous capsule, you got to make it really small, very thin. Repeated trauma causes the capsule to grow. I'm kind of running out of time, but if you want to do animal studies, you want to use animals that are not aggressive. For example, canines tend to be hypercoagulative and hyperfibrotic. They set back the heart valve industry at least 5 to 10 years. We worked on heart valves for about 10 years, and we couldn't get a heart valve to work in dogs. And finally, somebody said, well, why don't you try a more passive animal? So we tried sheep. We had over 100 heart valves. All 100 heart valves worked in the sheep. So that set us back 10 years. Okay, I think my last slide. Can stealth medical device be made for the bone? Yeah, I think that's a pretty good example of bone and hip implants. Soft tissue, yeah. Small sutures, anything bigger, no. Blood, yes and no. We've made long-term venous glucose sensors you can actually put in the heart, and they'll last for years. And so, bottom line is, I think in the soft tissues we haven't able to make a stealth biomaterial, but in bone and blood we can. And that's it. I went a little bit over, but any questions?
Do you leave this in the body, or there is a point at time that you have to remove it?
The implant?
Mm-hmm.
Are we talking about the glucose sensor?
No,
Oh.
the implant. The
SCS implant. Oh, the SCS, no, you can leave it in indefinitely. Eventually, the battery and so forth is gonna wear out, and you need to replace it. But hopefully, you can just replace the implant pulse generator, and you can leave the leads in.
I don't know if this is a good time to say, but we have Daniel here with us today, and he's working on a device that is the primary cell. Is that correct, Daniel? Mm-hmm. This is going to be it's not rechargeable, so it has its own battery. You just have to do the implant and explant number of times as you so.
There are patients that don't really do well with charging. They either don't have the mobility or the mental capacity, or they're elderly. So there are many patients which a rechargeable system isn't really suited well for. So for those patients, a primary system, basically a battery that you just throw away after a single use, a device is more appropriate. So after 3 years or so, the battery will die, and we can implant a new device. It's kind of like a pacemaker. Pacemakers have primary cells. You just every few years you just got to replace it.
I have a question. The very beginning you mentioned as a device, as a foreign body is introduced into the body, there is an adhesion at first, and it's either happening or it's not happening.
Well, it always happens.
It always happens.
Always happens.
But there was something that you said that it either would stick or it wouldn't stick. I missed that. I'm trying to trace that to the genetics of the person.
Well, it doesn't matter about the genetics of the person. Usually, when you put an implant in, if it's a biocompatible implant, usually it'll pick up serum albumin, and it won't denature. Form a nice coating of serum albumin on there. If it's not a biocompatible material, usually what will happen is it will immediately bind fibrinogen and fibronectin. And once fibrinogen and fibronectin bind to the surface, all bets are off. That implant, you'll never make it biocompatible. And it's the nature of the chemistry, it's the nature of the surface roughness, it's the nature of other factors.
So is that like an FDA stage that gets rejected, or is that something that a doctor would have to remove the implant?
I don't think you might not have to remove it, but what it's telling you is you're going to form a pretty thick fibrous capsule around it. And if you need to be communicating outside of the capsule, eventually you're going to have to take it out, because you're not going to get through that capsule. The fibrous capsule is avascular, it's collagen. It's very, very tough collagen. You might as well put it in a thick plastic bag.
Another question I have for the SCS device that you have come up with. Ballpark, how many patents are in there?
In our unit?
Yeah.
Oh God, maybe 30 or 40, something maybe at least. I would think. Some of them are kind of more remote than directly on the unit, but I'm sure we got at least in total probably, I don't know, more than 100.
Oh, my question was specifically that SCS today.
Probably at least, what do you think, Daniel? At least, probably at least 50.
It's a good guess.
Uh-huh.
Is the device more compatible? Or, and if not, is work being done to make it more compatible?
You know, we don't, I'll be honest with you, the three major manufacturers of the SDS devices, I would say all three are biocompatible. I don't really think that's the problem. I think where the advantages are is the ability to program and to do, and efficacy.
I think her question was an MRI.
Yeah, MRI compatible, not bio.
Oh, I'm sorry. All three companies are also working on MRI compatible devices. Some are a little further along than others. Yeah, because most of these patients, if you need a device for pain, you're probably going to need MRI some point in time. And then with all companies going to doing deep brain stimulation, I mean, literally 100% of all DBS patients get MRI. So we're all going to have to head that way. That's inevitable.
You mentioned your heart valve program. It started with the canines, it set you back anywhere from 5 to 10 years, and started on the sheep. And you got better results. Did you ever try it on pigs?
We did.
Okay. And sheep are better than...
The interesting thing about a sheep, if you pull a blood sample of a sheep and you submit it to a blood analysis for human blood analysis, it will pass.
Oh.
It is that close. The only difference between sheep blood and human blood is sheep's platelets are all messed up. They don't look like human platelets. But aside from that, the sheep was the closest blood model for human. For tissue models, pigs are better.
Pigs are better.
Okay, so, well, I mean, thank you, Mike. Thank you so much for being here today. We had a good group. I think we had the mad scientist himself. We have Wache, equipment guru here, and then Daniel. He's responsible for all the communication with the board and the remote control. So this was a good forum we had, and I proposed this to the AESA to bring him out and put this group together here today. So people come out and learn about the device, what's out there. Obviously, I was hoping there would be a bit of a bigger turnout, and I will make sure that Armin take care of that for the future. So thank you everybody for taking the time today and being here. Really appreciate it.